we know we will. We are going, heaven knows where we are going, but we know we will get there. We are going, heaven knows where we are going, but we know we will get there. We are going, heaven knows where we are going, but we know we will get there. Boom, boom, ti-boom, boom, boom. Boom, boom, ti-boom, boom, boom. We will get there. Heaven knows how we will get there. We know we will get there. We are going, heaven knows where we are going, but we know we will get there. Boom, boom, ti-boom, boom, boom. Boom, boom, ti-boom, boom, boom. It will be hard, we know, that the road will be muddy and rough, but we will get We are going, heaven knows where we are going, but we know we will get there. We are going, heaven knows where we are going, but we know we will get there. We are going, heaven knows where we are going, but we know we will get there. Boom, boom, ti-boom, ti-boom, boom, boom. Boom, boom, ti-boom, ti-boom, boom, boom. We will get there. Heaven knows how we will get there. We know we will get there. We are going, heaven knows where we are going, but we know we will get there. Boom, boom, ti-boom, ti-boom, boom, boom. Boom, boom, ti-boom, ti-boom, boom, boom. It will be hard, we know, that the road will be muddy and rough, but we will get there. Heaven knows how.
Good day, friends. I'm Dr. Sanjay Kalra, an endocrinologist from Karnal in India. Now, one day, the heart, the kidney, both of them actually, the left and the right, and the pancreas, they got together. And the topic that they were discussing was the well-being of the world, safety, peace, happiness, harmony in the world. Initially, they began fighting each other. The heart said, I am the most important organ in the body. If I stop beating, you stop living. The kidneys, they laughed at the heart and they said, it's we who excrete all the dirt. It's we who keep the world happy and clean. Without us, you would be a very dirty place, a very dirty body. And then the pancreas said, my beta cell, it's just 1 gram heavy. In a lean person, like our speakers, Dr. Sarah and Dr. Peter, just 0.8 grams. And without that 0.8 grams, no one can live. Finally, all these organs, they decided that we need to work with each other. We need to be with each other for health, for happiness, and for the sake of the entire world. Now, we may not be able to change the entire world, but we can certainly help our patients, individual people who come to us for their well-being. And to see how we can do that, how we can decode the nexus and improve the coordination between the heart, the kidney, and the pancreas, we have two wonderful speakers from across the world. A warm welcome to Dr. Sarah Jarvis, who is a visiting professor of general practice at the University of Huddersfield. Warm welcome, madam.
Thank you very much. It's wonderful to be with you.
Madam has received honoraria from various companies, persons. And if there is one disclaimer that I'd like to give on Dr. Sarah's behalf, that is she's a very person-centered doctor. So whatever you hear her speaking, whatever you see her in her behavior, it will be all person-centered. We also have with us, to give her company, Dr. Peter Lin. Warm welcome, Dr. Peter.
Thank you.
Dr. Peter is famous across the world. I've met him personally before. And because he is so famous, he has honoraria for various speakerships. And he is not only person-centered, he is also practice-centered. So when you hear Dr. Peter Lin speaking, you will understand how you can integrate newer knowledge, newer information into your practice. So Dr. Sarah, Dr. Peter, one by one, how does it feel to be part of this program? And would you like to take the side of the kidney, the heart, the pancreas, or maybe someone else? Dr. Sarah first.
I have to say, I would not take the side of any of them because, as we have discovered only too clearly in recent years, they need to coexist amicably because they are inextricably intertwined. And I think I will just point out that was a wonderful introduction, Dr. Kalra, if I may. I loved your story about the heart, the kidney, and the pancreas. But I think I'm clinically based as well. I have been a practicing doctor practicing GP and GP trainer for 34 years. Clearly, I qualified when I was 3.
Dr. Sarah, that does not give your age away. That's the best part. Thank you, ma'am. And Dr. Peter, whose side will you take? Would you like to take the side of the left kidney or the right kidney?
I want to take your side because it's always a pleasure to work with you. But you know what? I think in the past, all the specialists, we had to divide the body into little pieces because there was no way we can study the whole body, 100, 200, 300 years ago. So therefore, we focused on each organ only to realize that they're all interconnected. We can bring in the brain now, we can bring in your liver, we can bring in everything. And so I think what we're learning is that we're treating the patient holistically. And so therefore, by keeping all the organs working together, as you were saying, harmoniously, this is something that we need in the world right now, harmonious working together. Then our patients will really benefit. And that's really what we're here to talk about. So thank you for your leadership in putting this program together.
Thank you. Dr. Sarah, over to you. We have another person who has joined us, and she is not a panelist. She is actually the reason the reason why we are all here together. Her name is Liz. Taking her example again and again, we'll talk about the impact of cardiac, renal, and metabolic conditions on health. We'll then look at the benefits of Jardiance, which is originator Empagliflozin, on people living with type 2 diabetes, on people living with chronic kidney disease, and on people living with heart failure. So we'll see how one molecule, how Empagliflozin, the originator one, can impact people with type 2 diabetes, with chronic kidney disease, and with heart failure. And Liz will guide us through our journey. So we'll be a very person-centric, a very Liz-centric panel today. And then we'll try to summarize, we'll conclude, we'll ask everyone in the audience, people gathered from across the Middle East, to conclude for us. So warm welcome to everyone who is logged in here. Please feel free to share your comments, your critiques. We look forward to interacting with you. Dr. Sarah, over to you.
Thank you so much, Dr. Carroll. What a wonderful introduction and what a privilege it is for me to be here. Now, I'm sitting here in the United Kingdom in the middle of what we describe as a heat wave. So the whole world has gone into meltdown in the United Kingdom. I've been a broadcaster for the BBC for 30 years, and I've done 8 interviews already so far for regional radio stations on people for how to cope with the heat. I'm now going to tell you what the temperature is. It's 29 degrees. So I think you can imagine British people do not cope well with the heat. And having done my elective in Mumbai many years ago, I remember only too well how different that was. But the point is that regardless of where we are in the world, we are all healthcare professionals who work together. Dr. Lynn, Dr. Kalra, and I have come together. We are like the CRM system, the cardio-renal metabolic system, inextricably intertwined. And Peter, I don't know about you, but I remember the days when type 2 diabetes, you'd go and see a diabetologist, all they were interested in was your glucose. I remember going to the ADA meeting in about 2005, so about 20 years ago, and a cardiologist was there, and he stood up very smugly and said, I can save more lives with my drugs for your patients with type 2 diabetes than you can with your drugs. And there was so much competition in those days. And yet, as we heard from Dr. Kalra, as we see on this slide, we know that metabolic disease actually is more than just the pancreas. We need to consider MASH, metabolic associated steatotic hepatosis, as well, of course, as just the pancreas. But we're going to focus on cardio-renal metabolic from the perspective of the pancreas today. But it really has been a huge shift and a very important one, hasn't it? Peter, when you look at your patients, how many of them with type 2 diabetes or with CRM conditions do not have at least 3, I would say, of the conditions at the top? Is that fair? Is this your experience?
Fair. Very much so. It's just we didn't look for it before. Now when you look, everybody's got it.
Absolutely. And of course, when we consider that these conditions overlap, it's not remotely surprising. Living with obesity, as so many of our patients do today, brings with it the low-grade inflammation across all systems. And so many of these factors have, or so many of these conditions have multiple risk factors which coincide. And that, of course, is exactly why these risk factors, whether it's hypertension, whether it's a dyslipidemia, whether it's visceral obesity, whether it's smoking, can have an impact, of course, on the kidneys. We will be talking later about glomerular hypertension, the impact that that has, particularly with hypertension generally, on nephron loss, accelerated by metabolic dysfunction in type 2 diabetes. Then, of course, the heart. If we consider that 50% of patients with type 2 diabetes have, actually nearly 2/3 of patients with type 2 diabetes have evidence of left ventricular dysfunction within 5 years of diagnosis, we begin to see the impact that those joint risk factors that they have in common have on the heart, as well as on control of HbA1c. And then, of course, beta cell dysfunction, the so-called patient X. I still remember the days of metabolic syndrome. We don't talk about that anymore, but beta cell dysfunction, insulin resistance, hyperglycemia. And on the right, we have the tornado of the consequences. This is what happens when people have several of those risk factors. And I think this really is a key image of why we need to consider the whole patient, Peter. And that is what we in primary care aim to do, isn't it?
Exactly. Whereas we were just dealing with one thing popping up at a time, now we're able to deal with everything at the same time, which is really good for primary care.
And of course, what's so great is that we now have medications which have, if you like, added bonus benefits. So for instance, particularly with the SGLT2s, this has been a real seismic shift from my perspective. When I first became a GP, when I was a medical student, we learned about the importance of controlling HbA1c, and that's what drugs for type 2 diabetes were designed to do. Now, as we're going to see, we have the SGLT2s. Their first indication was as a treatment for type 2 diabetes, but then during the course of the studies, we realized that they reduced both cardiovascular morbidity and cardiovascular mortality. We realized that they reduced the risk of heart failure, both HFrEF, heart failure with reduced ejection fraction, and HFpEF. And of course, we now have HFmrEF in the meantime with moderately reduced ejection fraction. And what's more, they protected the kidneys. So it's really all coming together. And it needs to come together. Because if we think of the number of people who have these conditions, I have a nephrologist friend who, when we first got the indication for the SGLT2s and CKD, he said, "At last, people have remembered me. I'm no longer the Cinderella." For so long, far too long, I think, Dr. Calrell, we have ignored patients who have chronic kidney disease because so often it's silent at an early stage. But we must not underestimate the huge morbidity and mortality associated with it. So we've got these figures here, but we see that on average, not surprisingly, a 45-year-old female, for instance, who has type 2 diabetes and cardiovascular disease is likely to die almost 20 years earlier. And a female with type 2 diabetes alone without cardiovascular disease about 8.1 years earlier than someone of the same age who has neither condition. The equivalent figures for a man of 45 are 21.7 years if they have type 2 diabetes and cardiovascular disease, and 7.6 years if they have diabetes alone. So these things have a huge, huge impact on people's lives, especially when we consider a huge proportion of patients, chronic kidney disease, 11% estimated global prevalence, even higher, of course, among patients with heart failure, even higher among patients with type 2 diabetes. But the prevalence of type 2 diabetes, I fear, Dr. Calrell, when I was doing my elective as a medical student in India, I do remember some of the doctors almost laughing and saying, all this type 2 diabetes, you in the West, you eat too much, you have too much diabetes. That is no longer the case. We no longer have the monopoly on diabetes, do we?
Unfortunately, no.
Absolutely. So if we then think about that interconnected nature, we can see some statistics here. As I mentioned, 11% globally with chronic kidney disease, but if they have type 2 diabetes, it's up to 40%, up to 2 in 5 people. And we're going to see later why we really now need to be considering patients at an early stage, an early asymptomatic stage of chronic kidney disease, because we can make a major difference to that disease trajectory. Again, up to 60% of people with chronic kidney disease have cardiovascular disease. And we also see that up to 2/3 of people with heart failure have chronic kidney disease. One study suggested 30 to 40%. We have other statistics out there, but up to 40% of people with heart failure have type 2 diabetes. So we know that actually, if you have heart failure with preserved ejection fraction, for which we previously basically had no targeted treatment, there was virtually nothing we could do. And yet, if you ended up in hospital with an acute episode, acute decompensated heart failure due to preserved ejection fraction heart failure, your mortality rate was about 50% at 5 years. So these things kill. Heart failure with preserved ejection fraction is by no means a benign condition. So the interconnected nature. Well, we've already said those pro-inflammatory risk factors, physical inactivity, we haven't even mentioned yet. So many risk factors to consider. Living with obesity, abdominal obesity in particular, dyslipidemia, hypertension, smoking, and so on. So chronic kidney disease, for instance, resulted in 1.2 million deaths in 2017. It is now the 12th leading cause of death and rising, and an additional 1.4 million deaths from cardiovascular disease directly attributable to impaired renal function. That is 1 in 12 of all deaths due to cardiovascular disease in 2017. It's a major issue, and again, rising. A 40% estimated rise in a single generation between 1990 and 2017, and still on an upward trajectory. But going back to that idea, Peter, I saw the statistic that under 40% of patients with chronic kidney disease have care from a nephrologist more than 12 months before they each reach this stage of needing dialysis. In general practice, we are the ones dealing with virtually everybody, aren't we, with chronic kidney disease?
Very much so. And the kidneys don't complain. They just keep working, and it's only stage 4 or 5. Then you get some complaints. And that's why it's such a late stage if we're waiting for symptoms, and hence screening and looking for these things is so important.
But of course, they are all the time they're living with chronic kidney disease. They're not just more likely to die from that, but also more of them will die from cardiovascular disease than from chronic kidney disease. So heart failure and kidney function decline, interconnected. Again, one will often exacerbate the other. What we're seeing there on the left is a slide with a higher risk risk of incident CKD and incident CKD or mortality. If they've got heart failure, 4 times higher risk of CKD or mortality. If they just have, looking at incident CKD, 5 times higher risk of incident CKD if they have heart failure. So I think it's feeling generally tired, feeling generally under the weather, and therefore just putting it down to the stresses and strains of everyday life. But heart failure is also associated with a more rapid decline in eGFR. And of course, what we know is that with type 2 diabetes, again, we are predisposing people to CKD, the later stages of CKD. Predisposing people to CKD, the later stages of CKD. But this study to me is pretty terrifying. I mean, the fact that at CKD stage 5, not everybody knows that they've got a diagnosis of CKD is pretty scary. It is better than it was in the early 2000s, but even so. But look down there, stage 3B, with an eGFR under 45. Only about 20% of people gradually rising to about 30% of people are aware of their diagnosis. And it's so important that they become part of it. Now, this is where I'm going to bang a drum for urine ACR testing. It is something about which I feel so strongly. Very, very worryingly, in the UK, we had targets for annual urine ACR testing for all patients with type 2 diabetes under something called QOF, the Quality and Outcome Framework. And as a result, about 80% of patients were having their urine ACR tested at least within the last year. Once that came off our targets, that figure dropped to 40%. And we're going to be hearing later from Peter exactly why we need to focus on both of these. You've got a great animation of this slide, Peter, which looks at all aspects of it. But what we need to see here is that both rising UACR and dropping EGFR are independent predictors of not just end-stage kidney disease, the need for renal replacement, but also atrial fibrillation, acute kidney injury, hospital admissions, stroke, myocardial infarction, cardiovascular death. If you look in the KDIGO guidance, there is about 20 of these pie charts, which are divided up for each of these conditions. And the same picture emerges from both of them. Let me give you an example. A patient with a urine EGFR, with an EGFR under 60. So that would be diagnosed as abnormal on EGFR testing. But a stage A1, so normal to mildly increased urine ACR, has a 1.85-fold risk of cardiovascular death compared to somebody who doesn't have chronic kidney disease. But if they then move to A2, moderately increased urine ACR, their risk is 3.37-fold. In other words, it doubles with the same EGFR. And even if your EGFR is above 60, so you have, quote, normal G1 or G2 renal function, we don't know if you've got chronic kidney disease at all unless we check your urine ACR. And if the urine ACR is normal and your EGFR is 60 to 89, you don't have chronic kidney disease. However, if your urine ACR is A3, severely increased for the same level of EGFR, then you have a 3.6-fold increased risk of cardiovascular death. So in other words, as high as somebody with an EGFR below 60 and A2 moderately increased. We know that urine ACR is an independent predictor of everything: cardiovascular death, end-stage kidney disease, stroke, hospital admission. We also know the delayed CKD diagnosis is associated with worse kidney outcomes. Well, I think we kind of expect that, but it's also associated with worse cardiovascular outcomes. So we know you have a 63% increase with every year of delay in your risk of getting to kidney failure, and an 8% increase in your risk of MACE. We need to diagnose early, not just chronic kidney disease, type 2 diabetes, of course. And we know that there are common risk factors. Diabetes, hypertension are among the biggest, but they're not the only risk factors. Together, yes, they contribute to more than half of deaths from CKD. But Peter, I think if we're bad at checking urine ACR and measuring kidney disease in people with diabetes, we're even worse in other groups, aren't we?
Yeah, very much so. So at least in diabetes, we've been talking about it, but in hypertension, those kinds of patients, we've sort of lost the ball on that one.
Yeah.
So I think we need to move a broader testing strategy.
Absolutely. And of course, these are some of those other groups. We haven't even got in here people living with obesity. And certainly from my perspective, I want to consider those, because they are at high risk because of all those underlying risk factors of all of these conditions, including chronic kidney disease. So I mentioned that urine ACR is underutilized in people with type 2 diabetes and hypertension. And as you so rightly mentioned, Peter, even more underutilized in people who don't have type 2 diabetes and hypertension. But look at this. In hypertension, 90% of people in the US did not receive a combination of urine ACR and EGFR. Forget in the last year, in the last 5 years. Now, you're just over the border, I believe, in the 51st practice, because it's certainly what I'm seeing in mine.
Yeah, we are. And I think because at one point we didn't understand, because it was the 24-hour collection and all these other crazy things to get protein, it was too complicated. And then when they went to the simplified version, we didn't quite get that message out of how important it is.
Yeah, absolutely. I couldn't agree more. And of course, even now, we send patients home with a urine sample, and we don't tell them that this is a heart and kidney test. We don't tell them how important it is that they need to do it. And of course, we send them home to do it first thing in the morning. A colleague of mine has a glorious expression: if the pee is in the premises, put it in the pot. In other words, don't wait until the first thing next morning, because yes, you will have a slightly more accurate quantitative measure of urine ACR by using a first one in the morning. But actually, if you do a urine ACR in the middle of the day and it's high, you are well on your way to diagnosing chronic kidney disease without that early morning sample. And you can then contact them again and stress the importance of doing that second urine ACR. So I mentioned, of course, that chronic kidney disease increases your risk of cardiovascular disease and cardiovascular death. People who are over 65 with chronic kidney disease are 6 times more likely to die of cardiovascular causes than to develop kidney failure. And yet, if I tell my patients they've got chronic kidney disease, they go, God, am I going to end up on dialysis? And my point I don't make to them is, only if you're the lucky one, only if you live long enough to get there, because chances are you'll have died of a heart attack first. But of course, the big thing is that we now have a way that we can change that. And I love this. I love the fact that Melanie Davis is a woman. Sorry, Peter, but there haven't been enough women represented in guidelines and at the peak until now. And she is, of course, the lead author of the ADA ESD consensus guideline. And what's so fantastic about this guideline is that it is all based around the patient. What we are seeing here is the patient in the middle of their goals of care. Long gone are the days if you've got type 2 diabetes, exercise more, eat less, get your HbA1c under control. It's all about assessing the individual, considering the factors that might get in the way of them adhering to their treatment. Using a shared decision-making and motivational interviewing are, I think, Peter, we have used these for, gosh, probably 30 years before secondary care cottoned on, I think it's fair to say, in primary care, because we have known these patients lifelong, and we recognize that actually patients don't always do what they're told, and we need to get inside their heads to realize, to help them to. So how do we do something about this? How can we reduce that risk? Shared decision-making is so important. Where we have an open discussion with the patient, they are equal partners. I may be the one with the degree, but you are the one with the lived experience. You are the one who has to consider their diet all the time, who has to think about fitting exercise into their life. You are the one who constantly worries about their weight, who has to take the medication, who has to think about the side effects of medication. So you are every bit as important. And speaking of medication, why do people stop adhering? There are patient beliefs or patient rationales, their health beliefs, their cognitive ability, of course, their self-efficacy, other comorbidities, meaning they've got lots of medication. Depression can have a huge impact on your impetus to adhere to your medication as you should. Then there's the treatment, the method of administration, polypharmacy, side effects. All of these things have a huge, huge impact. And then, of course, over on the right-hand side, we have the societal aspects. We have cost. It does matter. We have access to medication. We have follow-up. But looking at one aspect that we can deal with really easily, let's consider this. Use of 2 separate pills almost doubles the risk of non-adherence. So this was an adjusted analysis, and patients in the double and triple cohort had about a 2-fold higher, in the case of 3 pills, a 2.5-fold higher likelihood of non-adherence. But even 2 pills instead of 1 pretty much doubled the likelihood of non-adherence, and importantly, with persistence. Okay, you say that. What happens if you turn that on its head and you give single pill combinations? Whatever study you look at, you see that you get better adherence overall. At the bottom, as you can see, really statistically significant better adherence by using fixed dose single pill combinations. And 5 studies together looked at over 17,000 patients. It really makes a difference. So we know that fixed dose combinations, Peter, make a difference. What about generic versus branded or originator medication? Does that make a difference?
Yeah, that's important because you brought up the point of cost. So therefore, everybody is sensitive to cost. Of course, we're going to, if I can get something for less, it's always good. But let me just point out a fact, and I think Dr. Kalra had mentioned the Innovator drug, like sort of being very specific about that, because what we see is that way back in 1984, there was this Hatch-Waxman amendment that basically says that a generic company can rely on the data from the original manufacturers because they did the big studies and all those kinds of things. So they can rely on that data because they're going to make a copy of it. And the definition of a copy is you use the same raw materials and everything else, and you have to show that you've got the same blood levels inside your body. Originally is to show that it actually works the same, but they basically watered it down to just saying bioequivalence just meant bioavailability was sufficient. But something has changed recently is that they're not using the same raw materials. So for example, dapagliflozin, there's a generic version of it. And in this particular case, the original dapagliflozin used the crystalline version of dapagliflozin, whereas the generic is using the amorphous solid. And as you can see, amorphous meaning it's kind of liquidy. They have to add things to it to make it stable, to make it into a pill. So therefore you worry about stability, purity, and will it actually behave in the same way that we're hoping for. So now you're using different raw materials to come and access this. The other issue with dapagliflozin is that right here, there are molecules that are attached here. And you'll remember organic chemistry, a molecule can be right-sided or left-sided. And so therefore we can attach it in these different things, and the right-sided doesn't fit very well into the receptors. And so therefore, can we get all 5 of those positions right, especially when you're starting off with liquid material to begin with? And so then becomes the question, what about bioavailability? Is it going to get into your body? Is it going to have the same effects? Will it have the same clinical outcomes? Because as Sarah was saying, there's kidney benefits, there's heart failure benefits, there's so many benefits. Are we going to get all of that stuff if these molecules are not starting off the same?
And I think it's fair to say, just because we've got a heat wave here at the moment at 29 degrees, that, you know, you talk about chemical degradation. Of course, we know that with most drugs, chemical degradation is more likely at extremes of temperature. And our audience is living in temperatures far more extreme than we have in the UK, and they consider that normal. So I think there's an even higher risk there, isn't there?
Yes, because with temperature, basically the pills will start to degrade with the heat. And so the good pills tend not to degrade because they test it at those things. And so therefore there's many processes. Is the manufacturing good? Is the raw material good? Are they storing it and shipping it appropriately? Here from our very own Dr. Kalra did a little study about generic dapagliflozin and the Innovator dapagliflozin. And what you see here in this study was very simple. Let's just look at the A1C. So here's the generic dapagliflozin, 0.76% reduction, which is very good, but the original is more like 1.2%. So that's quite a large difference between the two. And I don't want you to look at it as, oh, well, it's only a 0.5%. It's what is different about it that it's not able to perform the same. So then you start thinking about, if that's different, then are we going to have differences in outcome as well? And so this is just the A1C outcome, but what about kidneys and heart failure and those other things that really are important for our patients? What about empagliflozin? Just to show you, you know, we always think that these things grow on trees, right? Because originally it was from the apple tree. But if you look at empagliflozin, you take these two things and then you have to do some heat and temperature stuff, and then you put this stuff in there, and then you do more heat and temperature, temperature, all sorts of very interesting procedures that you have to do until you finally get empagliflozin. So the number of steps here with all these different specific temperatures, you can imagine that manufacturing this is very important to make sure that all the steps are done and that you protect the molecules, etc. So now when they're using different things to start off with, we begin to worry about how well it works. For the statins, we've had them for 30 years, and this argument about original versus generic has been around. So in Spain, they looked at people had cardiovascular events, and they said, look, what is the likelihood of these people having events based on taking a generic statin or a brand name statin? And you can see that the generic line in purple is about 31% higher. So therefore, statin is not working so well, you don't get the LDL reduction, then we are going to have difficulties.
And I can see that this is going to be exactly the same issue, because it's all very well to say less reduction in HbA1c. Oh, it's only 5%,
no big deal, right?
5 minutes, 6 millimoles per liter, 6 millimoles per mole. But actually, if you then translate that into why are we bringing the HbA1c down? Why are we protecting the kidneys? Why are we protecting these patients at high risk of cardiovascular disease? Because if we don't, the outcome is going to be more cardiovascular events, more chronic kidney disease events, and so on.
Right. And this is for the people that had an event. So secondary prevention, are they more likely to die? In the same study, 13,000 people, and you can see the generic line is higher. So therefore, if you're on a generic statin, you've already had an event, you're more likely to have a mortality earlier. So in other words, we need large databases to look at this, but perhaps what we should do is, very simply use the originals if you can, especially when they've wandered away from the original recipe, I guess, if you want to think about it that way. So Sarah, back to you. So now we've talked about a lot of things. How do we sort of put it together in this for our patients?
Well, the good news, Peter, as you mentioned earlier on, that we looked at these things in silos because we didn't know how to join the dots. Now we know, firstly, that they have risk factors in common, which is why they coexist. Now we know that not only can having one condition increase your likelihood of having another condition, it can also increase your likelihood of more rapid progression and therefore a worse prognosis if you develop a comorbid condition. And that's why we need to be focusing on the left-hand side. Early screening. Early screening is fine, but what do you do with it? You make the diagnosis. There are some terrifying statistics about the proportions in most countries across the world. Most patients, up to 90% of patients with biochemical chronic kidney disease, and in one European country it was 94%, they had biochemical evidence of chronic kidney disease, they did not have coding. So we need to make the diagnosis once we've done the test. And the test for chronic kidney disease means urine ACR as well as EGFR, because only that way can we get those patients early, in particular with chronic kidney disease, because we'd be getting them at the stage where their EGFR wouldn't necessarily diagnose them with chronic kidney disease. So all guidelines now talk about early screening and a multifactorial approach, whether it's chronic kidney disease, whether it's heart failure, whether it's type 2 diabetes, to manage risk factors and to reduce their risk of complications. And of course, as we mentioned, time was when you had a drug which did one thing. Statins lowered cholesterol. Sulfonylureas lower HbA1c, but they didn't do anything else. Now we have drugs such as Jardiance. It's shown glucose control in people with type 2 diabetes, but it's also, of course, if we consider the EMPA-REG outcome study, where the numbers needed to treat to prevent one death by the addition of empagliflozin were lower. In other words, it was more effective at preventing cardiovascular death than statins were in some of the early placebo-controlled trials, when it was still ethical to do placebo-controlled trials. So cardiovascular deaths, kidney benefit in patients with chronic kidney disease and or heart failure. And here's something that I never imagined prior to the publication of the EMPA-REG outcome study in 2015. We are now looking at these benefits for chronic kidney disease and heart failure in people regardless of whether or not they have type 2 diabetes. And That is why the studies, which you, Peter, I know, are going to be showing us very shortly, have resulted in pretty much every national and international guideline you can mention, recommending SGLT2s such as Jardiance at an early stage, considering the whole patient, a multidisciplinary approach across the spectrum of cardiac, renal, and metabolic spectrum. And I know, Peter, that you've been heavily involved in KDIGO. So this is an area close to your heart, isn't it?
Yeah, very much so. So for 10 years, there was no updates. And then all of a sudden, there's all these studies popping out.
Absolutely.
It was a plethora of recommendations, as you saw. And we wrote a primary care version and we tried to water it down, but it's still a big document. But hopefully, the concept is very simple. We now have multiple pillars of therapies, SGLT2s being one of the biggest pillars that we've discovered. So therefore, we now can do something about these patients that we find early.
Absolutely. And of course, the reason that you had no update to the guidance for 10 years is because there wasn't really much you could do apart from control their blood pressure and put them on an ACE or an ARB. Now, suddenly, all that has changed. But let's see, Mr. Moderator, if we have any questions. Dr. Kalra.
Thank you so much, Dr. Sarah. That's been a great discussion. And thanks, Dr. Peter. It's been such a beautiful conversation. I just love to keep on listening. Just keep on listening to both of you.
Well, I think we need to answer some questions as well, but that's very kind of you to say so.
Right. So there are questions, and we welcome people who've logged in from across the Middle East and Africa. We have people who have logged in from Turkey, from India. These are the extremes, and UAE, Saudi Arabia, Lebanon, Algeria, Tunisia, Morocco, Nigeria, Kenya, Qatar, Egypt, Bahrain, and Ghana and Mauritius as well. So people logged in from all across the globe, actually. It's like a mini United Nations. There is a question, and you said that the kidneys are non-complaining.
I said that they complain.
Yes.
They don't. Peter said they never complain. I said they don't complain at an early stage. Later on, of course, it becomes very different. And I think that we do see that morbidity associated with chronic kidney disease, particularly at stages 4 and 5, particularly stage 5, obviously a life-changing stage of chronic kidney disease. But I think, even at a relatively early stage, you do get perhaps some symptoms, rather like I also have an interest in women's health. And, we used to say that ovarian cancer was a silent killer. Actually, when we start looking for it, we realize that there are symptoms, but they're non-specific. And therefore, patients tend to put them down to the stresses and strains of everyday life.
That's the question coming from a listener in India. And she says, Madam, we understand that we should screen because we would like to pick up people with chronic kidney disease when they are asymptomatic. We don't want them to be symptomatic at all. But based upon history, family history, drug history, and maybe examination, what are the red flags where we should be more vigilant, where we should be more reno-vigilant?
Perfect question. A really great question. And I think that, it is important. Let's go back to that. Let's consider again that slide of who we should be considering screening. And I mentioned diabetes, of course, both types 1 and type 2, but also, of course, hypertension. And I think we are very, very poor. We saw that figure of 90% of patients with hypertension in the US not having testing within the last 5 years with both UACR and EGFR. But I think we need to think of patients with cardiovascular disease, patients with heart failure, anyone with a history of acute kidney injury, and people with a family history of end-stage kidney disease, or perhaps who died before they reached end-stage kidney disease or hereditary kidney disease. We also, of course, need to be looking for hematuria and proteinuria. But of course, again, we're not going to be picking that up unless we have patients who have got, unless we are checking patients' urine. So again, we need to go back to that idea. You need to do the checking. Now, there are some people, of course, with diabetes where you would consider non-diabetic kidney disease. And Peter, again, this is something that I feel really strongly about. If we look at EGFR results and UACR results, we tend to look at them in isolation. We don't look at the trend, do we? And of course, a patient of 50 with an EGFR of 60 could be at much, much higher risk than a patient of 85 with an EGFR of 40, couldn't they?
Yeah, very much so. And I think that's why the pairing of the two is so important. It would be like saying, okay, you've got high cholesterol and you've got blood pressure. Like they're separate risk factors, right? We
Yeah.
would measure both. And that's the same thing here. And for the person that's asking the question is for, as you pointed out, the groups that we should be just off the top of our head: type 2 diabetes, hypertension, cardiovascular disease, obesity. Those four groups already take about 80 or 90% of your patients that you normally see. And then occasionally you'll have a family history where there is some other things, or perhaps you might have swelling, those kinds of symptoms. So lupus and all those little bit more exotic kind of diseases are also part of this package of the non-diabetes kidney disease. And as we'll show you, the studies are including those patients now. And so we're finding that there's benefit for them. And once we explain the mechanism, you'll understand why diabetes, no diabetes, it doesn't matter. If they have CKD, they'll be beneficial. And then if you really don't have testing, then if you have a patient with diabetes, just start the SGLT2. In other words, if you tell me I can't access anything, and when we were writing the KDIGO guidelines, we said some places don't have ACR, they don't have proteinuria testing. So we said, look, if you don't have a test, then just put them on the drug that will protect them. So if they have diabetes, I can use an SGLT2 right off the bat for their diabetes. But the bonus is I'm going to get reduction in kidney and heart failure and things like that. One other
Exactly.
point that I would make is that if you have heart failure and I give you the drugs, your heart failure gets better, but your kidneys get better. In other words, they don't deteriorate. Whereas if you have kidney disease, your kidney gets better and your heart failure risk goes down. So in other
As
words,
does your risk of cardiovascular death.
yeah. So it's kind of
Absolutely.
a broad base, so you don't get hurt in one area just to get the other benefit. Like Lasix, it's good for heart failure, bad for kidneys, that kind of thing. So there's very little
Yeah.
trade-off.
So what's really interesting, actually, coming to your point, Peter, about being able to access them early in the UK, we've had a recommendation for SGLT2s within their license, and the guidance and license for Empagliflozin for chronic kidney disease is wider from NICE than it is, or the approval from NICE is wider than it is for other SGLT2s. That if you have a patient who has type 2 diabetes who is at risk of or has cardiovascular disease or heart failure, that you either consider or offer an SGLT2 regardless of the HbA1c. We've now also just finally, hallelujah, reached the stage in the last few weeks in the UK where instead of having to refer to a patient with heart failure to secondary care and get them titrated up on the maximum dose of all their other drugs before you could start an SGLT2, a process which often takes a year, we can actually now prescribe in primary care on the basis that, yeah, you're protecting their heart if they've got evidence of heart failure. But guess what? There's a really strong chance up to 2/3 of patients with heart failure have also got chronic kidney disease. So you're going to be protecting them from that as well.
And then one easy way to explain to a patient, why am I giving you a diabetes drug? Because a lot of times they'll look it up and ChatGPT says you don't have diabetes. It's just to tell them SGLT2. So the S is sodium. So sodium glucose
Exactly.
cotransporter inhibitor. So you're managing glucose, but you're also managing sodium. And managing sodium, as I'll show you, is good in kidney disease and in heart failure. So if you just explain it like that, then they go, oh, okay, it's a sodium management thing. Therefore, even if I don't have diabetes, I still need the sodium management. That's why non-diabetic kidney disease, non-diabetes heart failure also works.
We have lots of more questions. Some of them we'll take later, and we acknowledge the questions regarding dapagliflozin versus empagliflozin, and also regarding other classes of medications. But perhaps Dr. Sarah or Dr. Peter, you can take one of these questions each. There's one question from a viewer who says, what are the simple checks that you recommend at the primary care clinic? And they're very happy that you've pointed out that all this work, SGLT2 prescription, evaluation, everything should be done at primary care level. You do not need to refer to secondary or tertiary care. That's one question for either of you. And for the other person, the question is, sir, sometimes the guide is confusing. So in a couple of sentences, would you like to just summarize what are the commonalities between all the various guidelines from nephrology, from diabetology, from cardiology, and from across the world? What is common to all the guidelines?
So if I start and say the foundational treatments are now all common, and we do need to be looking for a patient whether they've got CKD, whether they've got heart failure, HFpEF, or HFrEF, whether they've got chronic kidney disease, and whether they've got diabetes. We need to be looking at their diet, ESD guideline, because actually for all these patients, we'll be doing exactly the same thing. They really are coalescing that closely, aren't they?
Yeah, so now they're trying to harmonize all the guidelines. So you don't have heart failure guidelines, kidney guidelines. And that's what's happening because we have medications that go across the full spectrum. So that's why, the SGLT2 goes across the full spectrum. And the reason why it's confusing is that when we write guidelines, we have to have a study. Then we can make a big, bold statement. And so when you have heart failure, SGLT2, great data. So that's why we separate out heart failure patients, CKD, SGLT2, great data, coming up, GLP-1, great data, finerenone, great data. So now we're collecting those ones. And then if you are high cardiovascular risk, so you've had a heart attack or stroke, bypass, or if you are high risk, like 60-year-old plus 2 risk factors, those kinds of things, also very good data. So when your patient fits into one of those categories, we have big clinical trials that we can say, this is what we can give to you in addition to any sugar lowering and those kinds of things. In the past, everything was about sugar lowering. So then one wasn't really better than the other. So you could pick whatever you want, SU, metformin, DPP-4.
Well, in
but when
terms
we started,
of side effects, some were better
right,
than others.
That's right. Yeah. So we would pick based on, less hypoglycemia. And then all of a sudden we had these results from Empagliflozin was really the first one that said, hey, by the way, we can do something extra. So it was a big safety study. Instead of just showing safety, it was showing benefit. So less death, less heart failure, less kidney disease. And so then people said, well, the sugar control is great, but we want these things. And that's when we started to put them into these categories. And now initially we weren't sure whether all drugs were going to do this, so all SGLT2s. So we had to go and check it out. So that's why the guidelines were a bit messy in the beginning, but now it's pretty clear that the SGLT2 class is a very good set of medications. GLP-1 is now having many benefits as well. So now you're going to see them. The guidelines will become cleaner as the data becomes tighter and tighter.
And you are now going to take us through the actual studies, aren't you, Peter?
Yes, we'll jump quickly, not painfully. So don't tune out. Okay.
So carry on, Peter.
All right, that's great. There was that other question that you had. Oh, primary care. Do that, and we'll take care of that afterwards. Yeah. Okay. So maybe do you want to just take us through this case? I think we just have this one case. So Dr. Kalra, do you want to just introduce us to Liz that you spoke so highly about?
This is Liz, and the basic reason why we are doctors is because we want Liz to be healthy. Liz and all the other men and women whom we take care of. So Liz has been diagnosed to have type 2 diabetes. She's been living with type 2 diabetes now, that is known type 2 diabetes for the past 3 months. But diabetes didn't come alone. She's also got hypertension. She's got dyslipidemia. And therefore, she's at increased risk of cardiac, renal, and other metabolic complications. She was put on her by her care diet and exercise. The doctor didn't advise any medication. Liz wasn't too keen on it. And her BMI is 29. Her HbA1c is 8%, which translates into 61.7 millimoles per mole. The next slide. And now Liz is afraid, of course. I mean, why should she's a young lady. She's obese. She had been able to manage that. She was navigating life with obesity. But now, then she got hypertension, dyslipidemia, and now diabetes, the entire works, the entire metabolic syndrome. She's worried. And Dr. Sarah, what she says is, Doctor, I need help. I would like to dance at my daughter's wedding.
Absolutely.
And that's 20 years away.
And of course, I think this is the real, we do need to help our patients. We need to get inside their head and understand what their priorities are, because that's going to be the best way of ensuring that they adhere to treatment and that they work with us to improve their lifestyles. But Liz needs to understand the truth. We don't want to scare her, because scare tactics don't work. We know that she is at very high cardiovascular risk if she has any history of this, if she has any vascular. Well, we've already seen she's got hypertension, she's got dyslipidemia, as so many of our patients at diagnosis with type 2 diabetes already had. And she is living with, well, close to obesity. their ethnicity. But if she was diagnosed earlier, she would have been at even higher risk. We've had several comments in about the cost of treatment. I think if patients understand how much more their drug is doing, their SGLT2 is doing than just controlling their glucose, it could be needing to leave work early. It could be allowing them to dance at their daughter's wedding, as Dr. Kalra said. It could be meaning that they don't need other family members to take time off work and look after them. Suddenly, it becomes a lot more cost effective and prioritize them more.
Yeah, that's true. So in other words, diabetes, most people understand it as being high sugar. And they say, well, I don't eat a lot of sugar, so obviously the understanding isn't quite there. But the problem with sugar within your blood vessel is that sugar sticks to proteins. And so therefore it's proteins within your blood vessel wall, and that makes the blood vessel weak. And so you and I have a lot of blood vessels. We have about 60,000 miles of blood vessels, as you can see here. And so that sugar sticking process is happening throughout the vascular tree. But certain areas is going to show problems. So that's why we have more strokes in people with diabetes, more retinopathy, more heart disease, heart attacks, as well as heart failure. Kidney disease is very popular because a kidney is just a big blood vessel curled up into little balls that we call glomeruli. And then we have peripheral arterial disease, we have ulcerations, we have amputations. So this is the list of the complications of diabetes from the sugar sticking inside your blood vessel wall. Now, if you have these complications, of course, you're more likely to die. So when we look at these big graphs of populations, it doesn't matter if statins and ACE inhibitors equally, people with diabetes still have a higher death rate. So therefore, we're always looking at how do we reduce death in addition to statins, ACE inhibitors, and those kind of medications. And so therefore, we look at our medications that we use for diabetes. Critically, just at death itself, you'll see that metformin can reduce in the UK-PDS trial, but there's no death benefit with metformin. If you look at SUs, for example, there is certainly no death benefit. There might be even a slight increase in death. So therefore, we would say there's no benefit clearly there. Insulin, even when we started early, like in the origin, started early in the diabetes stage, there was no death benefit there. Still, you to control sugars, but no benefit in terms of cardiovascular events. DPP-4s, big, huge studies looking to make sure that they're safe. And in those safety studies, we couldn't show any death benefit either. And that we got was SGLT2 inhibitors, right? So the Empareg study showed us a death benefit, which was a shock to people because it was a safety study. We were expecting just the line to be equal and not to be spread apart. So SGLT2 is one of them. And the other one is GLP-1. With the leader trial in liraglutide, that was another one where the death would separate. So now we have two classes of medications that can lower your sugar very well, but on top of that, there was death and MACE outcomes and other benefits that we're seeing. So today we're just going to focus in on the SGLT2. Next time we'll talk about GLP-1. And I think it's appropriate because GLP-1s, there is some cost attached to it, some side effects, and it may not be as affordable for most people, whereas the SGLT2 is still within reach of most patients in the sense that it's about the price of a cup of coffee, not Starbucks, cheaper coffee that's going there. So if you look at the Empareg study, this was a study done for safety. So the FDA, after the rosiglitazone disaster, said all diabetes drug must do a safety trial. You don't have to show me that it's beneficial, just show me that you don't cause harm. And in that study, the Empareg patients, they took them 7,000 something high-risk cardiovascular patients. They've had heart attacks, strokes, because it's mainly to show that it doesn't do bad things to people with diabetes. And so to everybody's surprise, the CV death outcome was actually separated. And so therefore, it was a reduction of about 38%. And it happened quite quick. So not only do you have a death benefit, but it actually splits apart quite quickly in the beginning. And so this caught the attention of cardiologists as well, not just endocrinologists. Cardiologists came in and saying, well, what's on here? Because they always thought diabetes drugs take 10, 15, 20 years before they give you cardiovascular outcomes. And that was true of the SUs, metformin, and the insulin. So this caught everybody's attention, and guidelines people said, we need to rethink about these SGLT2. And we had thought of them as just getting rid of sugar out of your kidneys and lowering sugar, and that was all that it was capable of. And now we're starting to see other benefits that we see here. Now, is it a class effect? People always ask me, that. So if you look at the EMPA-REG outcome, we saw that 38% reduction in death. And very shortly after that, the CANVAS program came out, which is a canagliflozin study, sort of similar population, high-risk profile, giving them canagliflozin. And what you see here is we couldn't see a separation in death. So before I sort of say everybody is good for this thing, maybe we just look at the studies and follow whatever was in the study that had some benefit.
And of
Now,
course, we also
EMPA-REG
saw in the Vertis CV study, which was an
Yes.
identical population, that
Right.
there was no reduction in cardiovascular
Correct.
death, effectively an identical population.
And that was ertugliflozin. And
It
so
was.
therefore, if we have cheap gliflozins that pop up,
Yeah.
let's just be a little bit careful about which ones we go with. Now, in the EMPA-REG study, they also looked at hospitalization for heart failure. That's a normal event that we capture. It's actually an adverse event, I guess, if you want to think about it that way. And what they saw here was also a empagliflozin of about 35% reduction in hospitalization for heart failure. And again, it was quite quick. So it wasn't like you had to wait months for the heart to get better. There seemed to be maybe a hemodynamic effect quite early on that kept people out of hospital. And so therefore, that would be a good thing, because heart failure hospitalization is the #1 reason why a patient with diabetes and cardiovascular disease would end up in hospital. So in other words, you don't have a heart attack and stroke every month, but you can certainly have heart failure every becomes the highest reason why patients would come in. So a reduction in that, very good for us. In the kidney area, they also noticed that if you look at all these outcomes of all the different types of patients, if they had proteinuria, as Sarah was talking about, EGFRs and things like that, everything was on the correct side. In other words, it was reduced if they were on the empagliflozin side. Now, remember, this was not a renal study. This was just for safety, but at the same time, they're collecting all this information and they noticed a benefit for empagliflozin. And you can see here, the one group that crossed over the line that didn't have benefit were people that had normal. In other words, they had normal leakage. There's no leakage, so you can't make them any more, but everybody else seems to have benefit. So all of a sudden, with one study, we were able to show metabolic benefits. So the sugars were coming down in these patients with type 2 diabetes, atherosclerotic heart disease, but you also saw heart failure coming down, and you also saw kidneys becoming better. And so that's where the birth of this cardio-renal metabolic, or whatever you want it came out to be, because one agent was able to cross all three. And that's when everybody started to get together. Just nephrologists and cardiologists started to get together and look at this molecule class. So Sarah, do you want to just go over the side effects? Because I know in the beginning, we're all freaked out about side effects of these things, you know, and we're told by the DPP4 people, they're terrible.
Interestingly, a meta-analysis has just come out today showing there was initially, do you remember the concern about urinary tract cancers? And it has come out absolutely confirming that there is no incidence. And it was a huge study, I think 132,000 patients or something. So yeah, I mean, we've really stopped worrying about an awful lot of these things. Likewise with urinary tract infections, there is no increase in any of the other studies. We saw them in the small studies, but not in later studies. Hypoglycemia, no significance, we do need to be aware that, of course, if you've got a patient who's on a sulfonylurea, hypoglycemia, or if they're on insulin, which of course we know can cause hypoglycemia, then you may need to adjust the doses of those. And, you know, we just need to be aware that in and of itself, if patients, for instance, don't have diabetes or they're not taking those drugs, there's no from placebo. There is an increase in genital infections, but you know what? Type 2 diabetes, how many of them haven't had thrush or balanitis? They've all got it. And I think that, you know, we are very, very clear that you need to do some counseling on. They need to understand the risks versus the benefits. And again, they need to keep that prize in the longer term, because the majority of these infections were one-off infections. They didn't require recurrent problems. I do have some patients, I don't know about you, Peter, have females who have recurrent vaginal thrush, and in those cases, although it's not a particular, you know, it's not a particular indication, not recommended, my personal practice is that I give them a course of treatment for recurrent candidiasis before they start treatment, if they're having it just for if they're having it predominantly for type 2 diabetes, because of course the glycosuria may make you more prone to genital infections. Worried a lot about volume depletion, about acute kidney disease. These patients in volume depletion, despite the fact that, for instance, in the heart failure studies, we were giving them in Emperor Preserved and Emperor Reduced, we were giving them to patients who were at very, very high risk. They were having all sorts of stuff thrown at them. They were getting, a lot of diuretics. They were getting ACE inhibitors and ARBs. They were getting all which could increase their risk of volume depletion, and yet there was no significant difference. Guidelines do recommend, I didn't mention their ketoacidosis. That's very much dependent on finding the right patient and making them aware of sick day rules. And we all know them now, but pausing rather than stopping the drug when they are acutely unwell. But of course, we know that the same applies to many other drugs: sad man's dog, sulfonylureas, ACE inhibitors and ARBs, diuretics, metformin, ARNIs, non-steroidal anti-inflammatories, SGLT2s, and the dog is for DOACs, direct oral anticoagulants, O for opioids, and G for gabapentin and pregabalin. All of these things, the patient is acutely unwell, can cause side effects. So it's just part of general advice we give patients. And again, we go back to this idea. I won't cover this, Dr. Kalra, in any detail now, but basically a reminder that all of those guidances are coming together, and the SGLT2s are absolutely foundational for all of areas, whether it's KDIGO for chronic kidney disease, patients with or without type 2 diabetes who've got chronic kidney disease, really important. First line therapy again for patients with chronic kidney disease, primary care diabetes Europe for any patient with type 2 and ASCVD, heart failure or chronic kidney disease, and again in NICE recommended for them if they're at high risk of any of those. And then over on the ADA ESD guidance and the ESC guidance, all these areas recommending SGLT2s such as Jardiance as first line therapy. Let's go to some more questions.
Yeah, just as we're waiting for questions, Sarah, I agree with you. So for all the hot countries, right, beyond 29 degrees Celsius, for all the hot countries, make sure people stay hydrated. So as we're sending out all this sugar in the urine, if the urine, then the concentration of sugar goes down, then the yeast infection is less. So drinking more fluids would help. And to your point about SADMANs, basically these drugs get rid of water, salt, and sugar. That's what comes out, right? So if you are vomiting, dehydrated, I need to keep your water, salt, and sugar. And so that's why we hold those medications. And I like the way you said hold and not stop. You usually say
pause,
stop.
Absolutely. If you stop things, they don't get restarted. So they are paused because you are losing those added benefits if you don't restart.
True. So Dr. Kalra, any questions that we should take care of?
We do have questions and comments, and allow me to take one comment first. This is from Nigeria. Happens to be my birth country. And to the colleague who has mentioned my full name is Sanjay Ayodele Kalra. So for those of us who are from Nigeria and to speak Yoruba, what does the word Ayodele mean to you? It's a nice word. Let's teach Dr. Sarah and Dr. Peter as well. Mutual mentorship. So that's a question to the people from Nigeria and from Ghana. What I mean, that's my name in Yoruba language. Our colleague from Nigeria, SGLT2 inhibitors are very useful. In fact, they have an insulin sparing effect. We are able to reduce the dose of insulin in many patients and actually wean people off insulin as well in some. So I'll continue with the comment, but the first question, Dr. Sarah, Dr. Peter, have you found this in your practice? But unfortunately, many patients, despite the fact that they're doing well. So what I would like to suggest is we use traditional Nigerian wisdom, proverbs, to explain to the patient why they need to be more proactive. A stitch in time saves 9. Penny wise, pound foolish. Stitch in time, they save 9. You can speak in Nigerian pidgin as well. Save kobos and end up spending nairas. Not 1 naira, but thousands of nairas. Because if you save pennies, you, let us say you save a few pennies or a few pounds or a few dirhams or dinars on your SGLT2 inhibitor prescription, you might end up with the dialysis unit or with the kidney transplant unit or get hospitalized for heart failure, and then you will have to spend lots and lots of dollars and pounds, which is not a nice thing. But the same thing, you don't have to say it in a bad way. This is a very pathogenetic, very disease-oriented way, what I just said. So why don't we convert it into, if you take this tablet, if you take Empagliflozin, it will keep your kidneys healthy. It will keep your heart and your kidneys young. You will live longer. Your heart and kidneys will be longer. All the blood vessels. So any kind of vascular bed that you are worried about, whether it be cerebral, whether it is cardiac, whether it is pelvic, pudendal. So you look at the age of the patient, the gender, and you use whatever is appropriate. It will keep your vessels healthy and young. So let's ask everybody in the audience, while we get Dr. Peter and then Dr. Sarah to respond, how would you use traditional proverbs and metaphors from your language? Please share with us. How would you convert pathogenetic into genetic language, salutogenic language, which is health-oriented, happy, optimistic language? So while we wait for these answers, and for that answer about iodelic, Dr. Peter, your comments. Do you see patients where you're able to wean them off or at least reduce the dose of insulin?
Yeah, definitely. And even in the trials, they have shown that the people on insulin, when they don't need to increase, and then a lot of times they can use less. In fact, we tell people your sugar may come down a bit, your insulin requirements will go down. The problem that we ran into is if we don't, they see their sugars come down and they think they can get rid of the insulin. And that became a disaster. Insulin, because they said, I'm cured from diabetes because my sugar is so beautiful. And we must tell them that the insulin sugar into the cell. So it's the only one that moves sugar into the cell. Nothing else will do it. And so therefore the SGLT2 cannot replace that job. It can help replace that job. So if you have people on insulin, that's why we want to make sure that they reduce a little bit, but don't stop the insulin. But definitely over like 2 years in the clinical trials, they use less insulin over that 2 years. And there isn't this increasing insulin that we normally see in trials. They did try it in type 1, because somebody's going to ask about type 1. What about type 1? And in them, guess what? Type 1, young people see their sugar go down. They stop their insulin, they get into DKA. That's a bad situation. And so the DKA rate was about 4% in the studies. And so people said, you know what, in the hands of the real world, if we have 4% DKA rates, that would be too high. So even though it worked beautifully for type 1s, they said it's just not safe enough because people will tend to stop the insulin. And to your point about how do we make patients understand, I now tell people about the study briefly. I'll say, 7,000 people like you and the people that took this live longer, or didn't have to have heart failure, or didn't have bad kidneys. So then they understand that we're not experimenting, like we actually know. And then number 2 is I had a patient that came in, they don't understand prevention, right? Sanjay, they don't understand when nothing happens, that's a good thing, right? So this woman was taking a DOAC for her atrial fibrillation for 7 years. And she slapped the pills down on the table. And she says, I've been taking this for 7 years. Happen, right? So
exactly.
I said, that's the whole idea. I said, oh my gosh. So now I've started to tell them, every time you get these prescriptions and nothing has happened, you haven't gone into a hospital, kidneys are good, no heart attack, no stroke, no heart failure, none of those things, it means it's working. And now they're very happy to refill. The only other thing I say is I wish I can just give them 1 pill a day and they just pay for 1 pill a day. Then we're down to a coffee level a day. The problem is we have to buy 30 pills at a time. So that would be like buying 30 coffees at a time. So it seems very expensive, but about a coffee a day, but it can protect all these things like those people in the study. That seems to help people understand a bit better.
So Peter, you have stolen my line, which was exactly about how much is it going to cost a day, how much do you pay? But I think really importantly, Sanjay, what we do also need to do in terms of shared decision-making is to ensure that we understand what the patient's priorities are. And, we can then say to them, every time you take this for 1 month, you are increasing your chance of dancing at your daughter's wedding, of seeing your grandchildren be born. And every month, nothing's happened. You are another month closer to reaching that milestone of retiring and moving back to your village, of whatever it is they want to do.
That's a very nice way of putting things. And so thanks, Dr. Peter and Dr. Sarah, for giving us these multiple perspectives. And basically, the point here is we need to know about empagliflozin. We need to know about the studies. We should be able to communicate properly. But we also need to focus on our communication, how we speak with our patients. And what Dr. Sarah is telling us again and again, first you listen to the patient. We call this therapy by the ear. So many times in India, I ask the younger boys and girls a quiz question. What is therapy by the ear? And many times the answer comes, sir, Boehringer Ingelheim is creating a new insulin eardrop, or maybe it was an eardrop. That's not right. Therapy by the ear means you listen with your ears, use your ears like a stethoscope, listen to what the patient is saying, understand what is important for them, what their priorities are, what their concerns and challenges are. Like our colleague from Nigeria said, the issue is economy, it's finance. And then you address that. And you can use the metaphor of coffee. You can talk about future benefits. You can talk about spending kobos and saving nairas. Suits the patient at that particular point of time. And once you've got this communication right, then things move forward very smoothly. Dr. Sarah, over to you, please.
I was just going to say, I think in the interest of time, we're going to have to move on, but we have all these questions coming in. I talked about side effects. Someone said, does this cause a side effect like Fournier's gangrene? Patients with type 2 diabetes of Fournier's gangrene, whether they are taking an SGLT2 or not. And the incidence of actually Fournier's gangrene, it was seen in the studies, but the incidence was not significantly higher than it is in other groups. We need to remember these patients are living with morbidity, with obesity rather. They are at high risk. So we need to tell our patients whether they're taking SGLT2s or not, to be aware of the early warning signs of Fournier's gangrene. This is not something, if I wasn't required to by my, as a result of the guidance, I probably wouldn't be doing it anyway, but because I am, I now tell patients whether they're taking it or not. We do not need to worry ourselves too much about Fournier's gangrene.
Hygiene is most important. So do keep on focusing on hygiene.
Yeah.
And many of our colleagues who work in the Middle East and North Africa, hygiene is an essential part of our religion, of our culture.
Yeah.
You have to wash yourself 5 times prayer. That is what hygiene is. So you just use that. See, religion tells us to be hygienic. Culture tells us to follow hygiene. And this is a kind of a metabolic hygiene. This drug is contributing to metabolic hygiene. So Dr. Peter, before we move on, could you expound upon this? You have a patient who is dilly-dallying. Should I take an extra pill or not? Let's use the word metabolic hygiene, irrespective of which background the patient is from. Would this ring a bell? Just imagine that I am a lazy, apathic, and not a very nice patient. Could you use metabolic hygiene to counsel me regarding proper therapy?
You could. And then in the beginning, what we said, this is the only class of drugs, SGLT2, where it actually gets rid of the sugar outside your body. Like it actually gets rid of the sugar that is too high. Some people like that concept. Like if you really want to go simple, is that we can actually get rid of the sugar. So now less sugar is sticking everywhere. So therefore your heart is going to last longer, your kidneys are going to last longer. And people understand sugar sticking. And so therefore, if we have less of the sugar, there's less sugar sticking and clogging things up. And that might be good. And then in terms of the hygiene down below, I always tell people the urine has sugar in it. So then if you leave that on the skin, then the sugar is going to let the bacteria kind of eat. And that's no good. So no matter what, we don't want sugar urine on your skin. So then we sort of narrow hygiene down, not just to say you should be hygienic, because a lot of people say, well, I am, but then just tell them if there's any dribble of the urine onto your skin, we have to wash that off. So have a face cloth or whatever that you're doing and wipe that off, because we don't want sugar urine on you at any moment.
A nice way, maybe not for all patients, but for many patients would be. So I might want to convince or motivate Dr. Peter in this. Sir, you're looking so handsome. What a beautiful shirt. What a handsome pair of shoes. The same way that you keep your shirt clean, the same way that you polish your shoes, that is what empagliflozin does. It keeps the blood vessels clean.
Dr. Kalra, I think we are going to need to move on because we only have 40 minutes and we still have 40% of the slides to go. I'm so sorry. It's a wonderful analogy.
Carry on. Yeah, and can
you want to take us through our patients?
Yeah, we'll go on with Liz. Dr. Sarah, if you could continue. But this question from Dr. Fatiha Mesaudi, probably from Algeria or Tunisia, she is asked in French, when should we combine GLP-1 receptor agonist and SGLT2 inhibitors? So if you could take, would Liz benefit from such a combination?
I think, Peter, why don't you cover that while I move on with the next, one? Do you want to, can you cover that very briefly, Peter?
Yeah. So in other words, the two of them together will have benefits. They're working on different systems.
Yep.
So if affordability is not an issue, because GLP is quite expensive, then we should do that. I think for most people around the world, SGLT2 is a good base, as Dr. Kalra was saying. And then if we need more in terms of weight reduction, fatty liver, in terms of those things, we can think about GLP-1. Excellent addition. It's just the cost is a little for most people around the world.
Yeah. Absolutely. And of course, it's another treatment. So I think that, again, it's already, the SGLT2s are already foundational treatment. But Liz, we saw her earlier. We now know that she has an EGFR 5 and a urine ACR of 20. So there are factors to consider. Peter, why don't you take us through and just remind us what we need to consider in terms of that EGFR and build on what you and I were talking about at the beginning of the session.
And Sarah did a beautiful job with the KDIGO guidelines. How do we translate that to patients? I think Dr. Question next. So EGFR is speed. So we just tell them we would like your kidneys to run at 60 miles an hour or higher. So therefore, if we tell the patient you're 30, then people understand that I'm half the speed, or at least it's worse. So EGFR is the speed at the filtration of your kidneys. I think people understand that quite nicely. Albumin-creatinine ratio is harder to explain. So this is the quality of your filter. So a good filter should keep in good stuff. And in our case, the good stuff is going to be albumin. We'd like to keep the albumin, which is a protein inside our body, and we like to get rid of waste products. So we'll measure creatinine, which is a breakdown of muscle. So in a perfect kidney, we should just have the creatinine going out. So if we're to calculate the albumin-creatinine ratio, then the albumin number is small divided by a big number, so that number would be very close to 0, so closer to leaking anything. On the other hand, if you're leaking lots of albumin, then when we do your urine, the albumin is going to be very large divided by creatinine, and so now that number goes up. So if you have a high ACR, it means that your kidneys are leaking. So one is speed and one is leaking, and so therefore they're two separate concepts to measure your kidney. And as you saw before in the KDIGO heat maps, what we said is this way is the speed getting worse, and we can actually put in low risk, moderate risk, those kinds of things for you. And then this way is where we talk about the leakiness. So going across this way is becoming more leaky. And as you could see over here, if let's say your EGFR is 90, are you here or here or here? You don't know. So that's why we have to measure this one to tell you which box you're in. And we can say that for all of these boxes going around here as well. And these are known as the KDIGO heat maps. There's a whole bunch of them. And as Sarah mentioned, there's one for all-cause mortality as an outcome, CV mortality as an outcome, acute kidney injury, kidney failure. There's one for who to treat, one for who to refer, one for how often you should be checking them. So there's different heat maps during your busy day. So let me just try make it really simple. This is the only good section in this whole map. So therefore, if your EGFR is above 60 and your albumin-creatinine ratio is below 3, and notice there's two different units here. So that's why we put 3 or 30, depending on which units you're using. So if you are below 3 or 30, then you're sitting over here. And that's the only group that's good. Everybody else we have to pay attention to. So if your EGFR...
I think, Peter, it's EGFR... Yeah, I was going to say, because it's actually EGFR over 60 and urinase.
Yeah,
so
that's right.
You've got there an all, but it's not,
all,
it's both.
Yes. Okay, so the EGFR below 60 is no good, or albumin-creatinine ratio above is no good. And so therefore, if you just look at those two numbers and that's it. So if you're if you're below 60, no good. And if you're above 3 or 30, no good. So then those people you have to think about. And that becomes the list of blood pressure control, sugar control, ACE inhibition, SGLT2, maybe GLP-1, and that whole list of stuff goes on with you, okay? So Sarah, take us through the studies, because the studies looked at different categories. Can you walk us through this one?
Absolutely, sure. The only reason I interrupted, and I apologize, Peter, was just to remind people you need both an EGFR above 60 and a urine ACR under 3 or 30. Now, we've had a question which came in about differences between the two studies, of course, the DAPA-CKD study and the Empagliflozin study. And I think it's really important that we remember that they are different populations. They were looking at different groups. And I think we really do need to remember the patients we see in primary care, both with and without diabetes with CKD, particularly patients without diabetes with CKD, tend to have lower EGFR, but may not have that same level of raised urine ACR. So the DAPA-CKD population was patients with and without diabetes are between 20 and 75, but they also had patients. They had to have the top end of moderately increased or severely increased urine ACR. They found that their drug helped that group of patients. The credence population was similar, except that the urine ACR had to be above 300, but they only had diabetes. They found that canagliflozin helped that group of patients. What we didn't know, however, is whether or not it was going to help if you had lower eGFR but no albuminuria. And I think it's really, really important, because in this study we had no evidence, going back to your earlier slide, Peter, patients who were normoalbuminuric were also going to be helped. And what we saw with the results of the Empakidney study, we're going to see, but I think it's important to say in response to that question that we don't know whether DAPA would help with patients with normal urine ACR but low eGFR, because they weren't tested in their study. And without the evidence, we can't assume. But these patients in the Empakidney study were included regardless of their urine ACR. Back to you, Peter.
Great. And so therefore it's a broader population base. And
Absolutely.
I think that's what the point of all of this thing is, right? Patients as possible.
Exactly.
For time's sake, I'm not going to go through too much detail. I'm just going to show you the main outcomes. So this is kidney progression or CV death. And what you can see here, this is the placebo group, which means lots of good medications already. The only difference is an SGLT is empagliflozin, and they had less events. And so the reduction is about 28% relative risk reduction, and the number needed to treat is only 28 people to protect one person from either kidney progression or CV death. So the number needed to treat is quite low, which means it's cost effective, right? The more people you have to treat, the more cost it is to get one benefit. But in this case, it's only 28 people that we have to treat. And the patients in this study were people with diabetes and non-diabetes as well. The secondary outcome, and I only pulled this one out, is because this is all-cause hospitalization. So are you more likely to end up in hospital if you're taking it or not taking it? So this is the placebo group in terms of hospitalization for whatever reason. And then here is the empagliflozin. So what you could see here is a 14% relative risk reduction, and number needed to treat is only 23 people. So this is good for the patient because they don't end up in hospital, but it's good for the system because we don't have to have these people coming in.
And
this
it's
could be
good for cost, for explaining to them, you know, hospitalizations cost the healthcare system, but they cost you. You have to take time off work. This is expensive stuff.
Exactly. And so all of a sudden you have less hospitalization, which is also useful for people. The other thing that I'll just pull out here is what happens when you stop the medication. So we know that the benefit is there in the study when people are taking the medication, but once the study stops, people come off the medication. What happens to them? Do they just all squeeze back together again and behave the same way? Or is there something that lasts for a bit longer? And you could see that when they stop their medication, something lasts for a bit longer. So the people that were originally assigned to the empagliflozin group still had lower events over time. And this is the overlap period where they're stopping. So there's the number there. And you can see about 21% overall. If you look at when they're taking the medication, 28% reduction I showed you. And then when they're off the medication, there's still this 13%. So in other words, there's this lingering benefit. So are we actually altering some anatomy or something like that that might have this long-term benefit? So how do these SGLT2 inhibitors work? So this is your nephron, blood coming in, blood going around and coming out. This is the urine that you're making. And in diabetes, there's two types of kidney disease. One is glucose sticking inside the filter, and that will clog it up and damage it. So anything that lowers sugar would be helpful for that. However, the other way to damage this filter by high pressure. Now, it turns out the pressure here, which is your systolic pressure, let's say it's 120, the kidney runs at half systolic. So it's a low pressure system. And so therefore, if you open this by mistake and you let in pressure, you will destroy the kidney based on the pressure. So it's not high in the sense that higher than your normal blood pressure, but it's high for the filter. And that's because when it's taking away the garbage, you don't want it to come that fast. So lower pressure. So remember low pressure sitting here. So here's how it works. Blood comes in, goes around. The sugar is very small molecule. So this filter cannot stop the sugar. So all this glucose in your body will end up in your urine. Now that's a problem because we need that for fuel, a pump. So the SGLT1, SGLT2 pumps will pump back the glucose. because it's a sodium glucose co-transporter, every glucose you bring in, you have to bring in a sodium. And this is happening in your body right now. In a patient with diabetes, there's lots of sugar here, which means there's lots of sugar in the urine. And so this pump is going crazy thinking you need all of the sugar back. And so therefore it pulls all the glucose it can back, which then means it has to pull a lot of sugar in it, sodium in as well. And so now your urine sodium goes down. Now that becomes a problem because there's a little police officer that's using this to decide, are you making enough urine or not? And so a low sodium means you're not making enough urine. He has no clue any of this stuff is happening. His thinking is you must be not enough blood flow going to the kidney. You're dehydrated. So he calls ahead and he says, hey guys, open up the pipe so that we can make a bit more urine, and also squeeze down the out pipe so you have some more pressure so that you can make more urine. And this is perfect if you're hydrated, but this patient is not in the desert. This patient has diabetes. So every day there's too much sugar here, which means this is happening, which means this is happening, which means this is happening. So now I've just made this pipe big. So now you let in the pressure, which will then destroy the filter, and therefore you get kidney disease. So let me show it to you this way. That's normal. And here's your diabetic kidney. The pipe coming in is too big. I just showed you why that is. And the pipe going out is too small. And so this is traffic jam right here. Okay. So therefore you got too much pressure in the filter. And if you put pressure on a filter, you hyperfiltrate initially. So that's why you'll see people with EGFRs that is 130, 140 in. And that's because there's this huge pressure pushing down on it. And if you push hard enough, you'll squeeze out more protein. And that's why you get proteinuria as well. Eventually, the renal cells die. And as they die, then the EGFR falls because there's nobody to do the work anymore. What do? You all know this. We give an ACE or an ARB to open the out pipe. And by opening the out pipe, you lower the pressure here, and therefore you protect those cells a bit. But you'll notice that the in pipe is too big. So you still have too much pressure here. So who's holding the in pipe big? It's that police officer. And all he wants to do is see sodium. So if I were to give you an SGLT2 inhibitor, it blocks the glucose from coming out, which now means the sodium will not come out. So the sodium stays in the urine. The police officer is happy. And then he calls back and he says, put things back to normal again. Now, notice it goes back to normal. It's not a vasoconstrictor, because if you vasoconstrict like an NSAID, you will kill the kidney because there will be no blood flow. But what this does, it brings it back down to a normal position. And that's why it even protects you against acute kidney injury. So now we've got normal pressure and we've got normal filtration. There's less proteinuria and the renal cells will last longer. Also, if I close this pipe down, then the filtering speed slows down. Pressure goes down. And so we expect that your filter is going to slow down a little bit. So we expect a little drop in the EGFR because we're now decreasing the pressure in the filter, which in the long run is a good thing. So can I show you this study? They followed these people for a good long time. And here's the EGFR over time. And I just want you to follow the black line. So the black line is giving the ACE or ARB. So you're opening the out pipe. Pipe is still too big, so you still get deterioration of your kidneys. Now, don't get me wrong, if you didn't open the out pipe, the deterioration would be even worse. But the ACE and ARB cannot control the in pipe, so no matter your in pipe is still too big. So let's go and close the in pipe for you with an SGLT2 inhibitor. And so now you can see that the EGFR is much healthier looking. It's not exactly flat, it's still going down, but this difference is what the nephrologists were excited about, because now you can control both pipes on each side of the filter. Now, in non-diabetes kidney disease, how does it work? And this is where it's Peter Lind fake news. So there's no published paper on this, but this is what we think is happening. Okay, so here are all your nephrons. You have, let's say, about 1 million of these. And let's say you have, hypertension, nephropathy. So now you get rid of half of your nephrons. So half of them are, now you've got CKD, nothing to do with diabetes at all. Now, there's a problem because your body has the blood flow through your kidney. So how does it do it when half the nephrons are gone? What it does is that it opens this pipe. And by opening this pipe, I can push more blood through the remaining nephrons. So I've just created the same problem, right? This pipe is too big, and I'm now letting in pressure to destroy the filter. The problem holding this pipe open, it's probably sympathetic tone, something like that, but we don't know how to get rid of that. However, I do know it's not the police officer's fault this time. It's not his fault. And that's because these people don't have diabetes, so their urine sodium is perfectly normal. There's no problem with it. However, I do know how to talk to this guy, okay? And I know that if I give an SGLT2 inhibitor to then basically it stops the glucose going out. I'm going to leave more sodium in the urine. So in a normal person, I can actually leave more sodium in the urine. And if the sodium urine goes up, your police officer is going to say, oh, you're making too much urine. And so therefore, when he sees a high urine sodium, he will call back and close the pipe for us. And therefore, now you close down the pressure, and then you protect the kidney. So we think that that's how it's working in non-diabetic kidney disease. Nothing to do with glucose, everything to do with sodium. And that's why it makes sense in non-diabetic kidney disease as well. In terms of the EGFR, I remember the nephrologist got very excited by this graph. And this is the drop in EGFR. And I said, are you kidding me? Like this one is minus 2.75 per year they're losing. And the empagliflozin is minus 1.3. And I said, oh my God.
All of those add up.
Yes, that's right. And the key is that this is over 3 years, right? It's a tiny difference over 3 years. But what about if we take you out to 25 years? And so we can actually figure this out. So let's say the Empakidney study, average age was 64. They came in with an EGFR of 37.4, so quite bad. So this is where they came into the study. This is when you get dialysis, is when you hit 10. So therefore, in the beginning of the study, we showed you what happened in that 3-year period. So let's just follow them out after that. So let's say here's the placebo group dropping at minus 2.75 every year. I can calculate that you're going to hit dialysis at around 74 years of age, about 10 years later. And then what we could do is look at the empagliflozin group, and they were dropping at minus 1.37. And so you could see that they will not hit dialysis until 20 years from now when they're 84 years of age. So by having empagliflozin on board, you've delayed dialysis which is a huge benefit for our patients. Now, what happens if we follow our rule of 60, right? If your EGFR drops below 60, you got to get these people on it. Well, let's just follow the same line. And let's go here. Now look at it. It's extended all the way out to 100 years old. So another 16 years on top if we started early. And at 100 years old, you might have died of something else. Your wife killed you. But in other words, dialysis doesn't have to be in your future. Started up here, 85. Then you may never see dialysis. So this is the idea that we can avoid dialysis completely if we start these agents earlier. And so therefore, keep an eye on that EGFR, ACR. As soon as it crosses, we can do it. But even before it crosses, for your diabetes patients anyway, we can give it to them, and then we will have this protection kind of going with them as well.
So really important just to point out that, of course, the average age in Empakidney was 64. Increasingly, Peter, and I'm sure you are too, seeing people at a much earlier stage developing diabetes in their 30s and so on. And the figure, if you started an EGFR of 85, for which, of course, we need to be checking the urine ACR to know they had chronic kidney disease, you could delay it by 26.6 years. Now, that really matters if you are 30 or 40 when you develop chronic kidney disease.
Yeah. And so how do the guidelines kind of fit and meld all this together?
And that is exactly why we've mentioned several times, you start with the basics, of course. They have chronic kidney disease, whether they have cardiovascular disease, whether they have heart failure, risk factors for any of those things, you start with the basics: healthy diet, physical activity, smoking management, and I would add there, shared decision making, understanding their priorities so they start to prioritize their own health. And again, I've just become a grandmother. I know that I have been terrible at prioritizing myself because there was always somebody else. But if we don't do that, it's like when you get in an airplane, always put your own oxygen mask on before helping others. If we're not in good state, we can't look after other people. So we start with the basics, we get them on board with the basics, and then we look at those foundational treatments. These are pillars of drug treatment, first-line treatment. SGLT2, you can initiate and continue if the EGFR is 20 and above. And the KDIGO practical guidelines now says that actually if it's been started when the EGFR is above 20, it is reasonable to continue when it's below 20. But most of our patients will have an EGFR significantly above 20. SGLT2, first line treatment. Metformin, likewise, first-line treatment if, of course, the patient has type 2 diabetes and an EGFR above 30. We do need to worry about metabolic acidosis, lactic acidosis if it goes below that. RAS inhibition, we've seen, really important. I love your analogy of closing down the outflow pipes and the inflow and the outflow. Really, really important there. But RAS inhibition we've used for many years, but it was what we've had for many, many years. That's the reason there haven't been any new guidelines from KDIGO for 10 years. Of course, these patients, again, 6 times more likely to die from cardiovascular disease than they are from chronic kidney disease. These people are high risk. Give them a moderate or high intensity statin. I mentioned, Peter, the new drugs coming along, the GLP-1s, the non-steroidal, and so on. And of course, they are additional risk-based therapies as it stands. That may change in the future, but who knows? What we do know is that for now, SGLT2s are there as a pillar foundational treatment. And again, across the metabolic spectrum for CKD with type 2 diabetes, for CKD heart failure, or for CKD on their own. In the interest of time, we'll move. I think, shall we leave the questions till the end and try and crack on and do that last brief session, just in the interest?
We end, but we do have a comment if both of you could take that. You've alluded to metabolic memory. So a comment coming in from India is that here we use the concept of if you
I haven't, but I will now. I love that.
And then from the UAE, we have another comment in Arabic, which says that we can use the Arabic word suluk. Suluk means the behavior, the choices, opportunities that you take. So SGLT2 inhibitor related suluk means we make the right choice time, and that leads us to beneficial metabolic suluk, which means we get or metabolic qadar or suluk. These are Arabic words that they're using for karma. So we can use these concepts, and Empareg seems to be speaking in Arabic or Hindi today. One comment, from a Greek-speaking person who says that 20-kilometer long blood vasculature or endothelium in the kidney. And of course, in the entire body, it's 96,000 kilometers, which is again lots and lots of kilometers. 96,000 kilometers of blood vasculature. So if you're able to fix that up, if you're able to give clean vasculature, metabolic hygiene, if you're able to use SGLT2 inhibitors to clean all that endothelium up, you will be able to help your patient a lot. But Liz got stuck. Dr. Sarah, what happened to her? She didn't follow her doctor's advice.
Well, unfortunately, very, very sadly, of course, what we all too often see is that patients develop type 2 diabetes first, and then, of course, they go on to chronic kidney disease, which, as we've heard, all too often is not recognized, is not formally diagnosed, therefore is not treated. And then, of course, all that sticky glucose, I think it's fair to say, goes on and results in damage to the heart as well. And we've heard in hot weather, of course, the increased risk if you exercise in hot weather, the increased risk of heart failure. But Peter, we have changed a lot. When I was a girl, it was just heart failure. It's a lot more complicated now, isn't it?
Yeah, it is. It is. But it basically, we're now back to the EGFR. We now have the ability with echoes to measure that. And of course, you knew that, if the ejection fraction is less than 40%, so you don't move out 40% of the blood, then we call it heart failure with reduced ejection fraction with the little r there. So typically, this would be your heart attacks. Therefore, it's no longer pumping well. And therefore, the rest of the body doesn't get enough blood and therefore complains, and you have all the symptoms of heart failure. But then we started discovering another group, which was people with preserved ejection fraction. So their ejection fraction is more than 50%, and yet they still have the symptoms of heart failure where the rest of the body is not getting enough. And in this case, it's because the heart cannot accept the right amount of blood. So think about a hypertrophic ventricle. It can't accept the right amount of blood. It's pumping very well, but it's not pumping out enough. And so therefore, the rest of the body still feels lack of oxygen and lack of blood, and therefore you would still have the symptoms. Equally high risk in terms of those patients. So we started to see that population. And as you pointed out, now there's a group in the middle, which is between 40 and 49%, which is the mid-range kind of ejection fraction people. And the thought is, do they behave differently? And in the past, we know that, ACE inhibitors, beta blockers worked very well for reduced ejection fraction, but nothing really worked well for the preserved ejection fraction. We tried really hard, but we couldn't get a statistical benefit in clinical trials. And then we had another group of people, as we started to have more medications, we said some of them actually start off as a reduced ejection fraction, but because of our good treatments, they actually increase, and now they're above 40%. And so now they've called those the improved people, right? In other words, on therapy, they've gotten better. And that's because we're trying to predict the risk of dying. In other words, if I got you on therapy and then you're up there, that's different than somebody that's up there naturally. And so they were really trying to sort these patients out. Maybe it's an insurance company that wants all these categories, but nonetheless, for us, it became very complicated for us to think about. And so therefore, thankfully, the SGLT2 inhibitors have gotten across this whole stage. So for example, if you look at the Emperor Reduce trial, basically, here are the graphs. There was about a 25% relative risk reduction. You could see here that it happens really early. So you could see here all the way down to just 12 days on therapy, you're seeing the two graphs separate. Here we see about a month or so. You can see at day 34, we now have nice separation as well. So in other words, that's why the urgency of getting people on the medication. So if they have heart failure, they should be honest, because you don't have to wait a year or two for benefit. It kicks in very quickly, and we need to protect people very quickly. So that's the reduced ejection fraction people. And that was, of course, diabetes or no diabetes as well, because we're managing the sodium. Most likely, that's the benefit of it. But there are other mechanisms that people are working on. But the easiest one is just to tell them it's managing sodium for you. People all understand that that would be good for heart failure patients. For the preserved ejection fraction, they did the Emperor Preserve trial. So in other words, the people designing these studies knew that we were having these clinical dilemmas. And so therefore we said, let's tackle this group. And we were very surprised that there was a separation, because prior to this, all the studies are lines that look like this, and the p-value didn't quite make it. In this case, you could see a nice p-value with less than 0.0001. And so therefore, it's a 21% relative risk reduction. You could see here, absolute risk reduction between these 2 points is 3.3%. And if you want to calculate the number needed to treat, you just take this absolute difference between these two and divide it into 100. And so the number needed to treat is 31 people for about 3 years. And you can protect one person from either cardiovascular death or heart failure hospitalization. And again, you notice that quite early on, you already see the separation. So again, we don't have to wait years and years and years to see the benefit. And in this case, again, diabetes, no diabetes people were very good. So now all of a sudden, yes, these medications were for our diabetes patients. But now we can see a group of people who have kidney disease or have heart failure, either preserved or reduced, where we can actually use these medications for them. So it's becoming a broader therapy for our patients as well. So Sarah, do you want to take us through the final? Because I know that this is the last race part where we summarize everything.
I mean, I think just to very briefly to comment on the Emperor Reduced and Emperor Preserved, the great thing, a numbers needed to treat of 31 is impressive anyway, but this was against gold standard treatment. And the problem we have is with preserved ejection fraction, we don't really have any gold standard treatment. Whereas in Emperor Reduced, the numbers needed to treat was 19 to stop one person dying or ending up in hospital. And that was despite gold standard treatment. So again, Dr. Kelleher, going back to your comment about, what do you say to your patients? Well, if I treated 20 people like you, I could stop one of them from dying within this incredibly short space of time. So, and that's despite the fact that they were having all the other treatment. So that's why we see these results and we know that they absolutely make a difference. Again, a numbers needed to treat of 19 compared with gold standard therapy. This is not against placebo. This is against standard of care treatment. A numbers needed to treat in preserved ejection fraction of 31. And that's with and without type 2 diabetes. It is with and without chronic kidney disease. So we are really making a difference compared to gold standard treatment. It's also got a proven safety profile. I mentioned this earlier, but basically we saw exactly the same issues. We've mentioned, of course, Fournier's gangrene as well, but really, these figures were really very, very low. And if your patient doesn't have type 2 diabetes, you don't need to worry at all about ketoacidosis. So guidelines, surprise, surprise. They have done exactly the same in heart failure as they did in chronic kidney disease. They have said that these patients should be getting SGLT2s as foundational treatment. Class 1A, Class 2A, the highest, the strongest recommendation within the available therapies for both heart failure with moderately reduced, MUREF, and heart failure with preserved ejection fraction, which Peter explained so brilliantly just now. So if we just then think about our summary and conclusion, let's pull everything we've done already together. Liz, when she started, she just had type 2 diabetes. Well, we've seen the results there, but she was at high risk of a cardiovascular event because of her other risk factors. And we see there that the EMPEROR outcome with these patients, of whom 1/3 had not had a heart attack or stroke, by the way. So my cardiovascular disease included much more than just heart attack and stroke. We see that 38% reduction and numbers needed to treat of 46, equivalent to indeed even better numbers needed to treat than we see with the HOPE trial with ACE inhibitors and ARBs in patients at high risk, and indeed with the 4S trial in patients with statins. Heart failure, we've seen those incredibly impressive results with those really low numbers needed to treat for a condition which has a very, very high morbidity and mortality rate, and of benefits as well, and numbers needed to treat of 26 across by far the broadest spectrum of your patients, including all those patients with an eGFR below 45 who did not have microalbuminuria, did not have raised urine ACR. It can be prescribed with confidence by primary care practitioners. I prescribe it all the time. I've probably done so from an earlier stage than many others because I had a particular interest. Everybody I know now feels confident in prescribing it, whether it's for chronic kidney disease, whether it's for heart failure, whether it's for type 2 diabetes. We've seen those results. Why you select Jardiance? We do need to think about the fact that they need to be hemodynamically stable. We do need to give advice on cleanliness. I loved Dr. Kelleher's explanation, reminder on cleanliness. We have an expression in England which is cleanliness is next to godliness. And I think that probably would work across the board there. So as we already mentioned, I would say most of the studies, they reduced the dose of sulfonylureas, patients who were taking them for type 2 diabetes, by 50%, and reduced the dose of insulin by about 20%. I seem to remember, Dr. Lynn, is that correct? Among patients with type 2 diabetes in the studies, because we do want to reduce the risk of volume depletion and hypoglycemia. Genital hygiene, we've already said. Sick day rules, really important if you've got a patient with type 2 diabetes, not just for SGLT2s, for all those other drugs, as Peter explained. And then in terms of follow-up, we've had several questions about monitoring. Yes, you do want to measure their weight, their blood pressure, their HbA1c, their kidney function. We want to do that anyway, but if you're measuring kidney function, please do check their urine ACR as well as checking their eGFR, because both of them count. Peter and I If we've said it once, we've said it 100 times in the course of the last 2 hours. And please, please do think about adherence to medicines where single drugs, combination drugs may produce much better effects. Remember the doubling of the discontinuation rate among patients who are treated with 2 drugs rather than 1. Established safety profile, I've already mentioned. Again, ketoacidosis, uncommon to rare, but if you select the right patients, if you give them the right advice, we can move it way over towards the rare rather than in the uncommon. But early, if there's one word I'd like you to go away with, please, please, please today, it is early. Early screening. Once you've done the screening, record the diagnosis, because if you don't have a diagnosis recorded, they can't be systematically monitored. They can't be treated with life-saving drugs. It can help patients by treating them with Jardiance, SGLT2s such as Jardiance in chronic kidney disease, in heart failure right across the ejection fraction spectrum, and in type 2 diabetes and cardiovascular death. But we do need to think of the whole patient, because those systems are interrelated. We've gone all the way around and we have come back to that idea of the interrelated cardio-renal metabolic system. Every international guidance I've shown you has recognized it. We have a duty for the sake of our patients to recognize it. I think we're there. Couple of minutes for a couple more questions, Dr. Kelra.
Thank you so much, Dr. Sarah, Dr. Peter. A great presentation, and the message comes across to all of us, whether we are French or English speakers, Anglophone or Francophone. The message is loud and clear. Let me summarize in the next minute or two. The heart, the kidney, the pancreas, we spoke about them at the beginning. They realized right at the very beginning that they need to work together for better health. The nicest thing is that now we have a drug which can help all three. So SGLT2 inhibitors can be used in a very proactive manner to prevent disease and to promote good health. And these SGLT2 inhibitors help not only the heart, not only the kidney, the left and right both, but the pancreas as well. And they help the endothelium, the entire vasculature of the body. They help each and every organ system. If we are able to start in a timely manner, in an early manner, and would this be right, Dr. Sarah, if I said no time is too early, we should start as soon as possible?
Well, if we consider, of course, again, going back to that idea, regardless of HbA1c, if the patient is at high risk of cardiovascular disease, if the patient's at high risk of chronic kidney disease, if they're at high risk of heart failure, yes, regardless of HbA1c, so at the earliest possible stage. Again, going back to Peter's slide on starting early with an EGFR of 60, where you have that 16 years reduction, but even better, start with an EGFR of 85, and you can delay, looking at that modeling, and it was a modeling paper, you can delay that progression to end-stage kidney disease by 26 years. These patients, particularly the earlier ones who are at high risk, they have aggressive disease, and they deserve a long and healthy life, just like the rest of us.
Yeah, and to that point, so if you have a patient with diabetes, that's why SGLT2 should be on top of mind. The European cardiologist said, look, if you have diabetes and you're high risk, then you should go on an SGLT2 or GLP-1 first before metformin. Like, they were very aggressive, right? And they said the reasoning for it is because metformin's study that showed the heart attack reduction was done in 1999, right? So not everybody was on a statin, not everybody was on an ACE inhibitor. Whereas all of these new trials is on really good therapy, and then you add them on top, and then you're seeing these extra benefits. So they've actually pushed ahead and said, you know, we think that the first line should be SGLT2 and GLP-1 for your high risk. And their definition of high risk is 10 years diabetes, 1 risk factor. That's it. So smoking plus 10 years diabetes, you're high risk. So their bar is quite low. So maybe we should start setting the bar a little bit lower. So SGLT2 is for all your diabetes patients. We can think about that one. For your kidney patients, SGLT2. For your heart failure patients, SGLT2, regardless of, you know, diabetes or no diabetes. And I always tell my residents, you know, think about treating your mother. You know, now that you know all this stuff, like, wouldn't you want her to be on that? And then think about treating your mother-in-law. There would be somehow difference.
I'm afraid that's one I use very, very regularly. Yes, I would say, which one would you like your mother to have? Or which one would you like your mother-in-law to be deprived of?
That's right.
But
One of the doctors said, no therapies, no therapies.
So not only secondary and tertiary prevention, SGLT2 inhibitors like Empagliflozin should be an integral part of primary preventive therapy. And you should be able to counsel your patient. We call this VAT, value added therapy. So when you write a prescription, it's therapy. But how do you add value? By communication, by motivation, by counseling, by talking about hygiene, and by telling them that this is a preventive therapy. We're going to prevent disease. We're going to promote longevity and promote good health. A couple of questions, if you allow for 1 minute. Dr. Peter, Dr. Fozia Merili asks, she is francophone, so if you could speak slowly. Are there any other tests that we will use to assess the effectiveness of therapy, apart from renal and cardiac tests, apart from what we do routinely?
Yeah. So in terms of, let's say, the medication, you're starting an SGLT2 inhibitor, really there's not much to monitor, right? We don't have to focus too much. We don't have to repeat an EGFR immediately or anything like that. The one thing that I do tell patients and physicians is that if you're going to check the EGFR again quickly, the EGFR may come down a little bit, right? Because we're closing the pipe, so the filter is going to slow down, which is good because it's not overworked. So your EGFR may come down a little bit. So I always tell patients that. Otherwise, they'll say, you told me this was good for my kidney and now my EGFR is lower. You're a bad doctor, right? So I think we should talk about that stuff. In terms of should we be measuring, let's say, echoes? Should we be measuring pro-BNP? Pro-BNP is now coming to be a very, very good marker of heart failure, a good marker of who's going to die in the next 6 months to a year. So that testing is good, but it is costly and it's not available everywhere. Echoes are costly, not available everywhere. So that's why a lot of times I'm now telling people that don't have access to a lot of these things, let's just put them on the medications that we know would work. So in other words, you can't get an echo, you can't do this, but they have diabetes. Okay, let me just put them on the SGLT2. So for the coffee a day, I've now got them protected from their kidneys and their heart and those kinds of things. So in other words, instead of looking for people, and if you can't, afford the looking part, let's just afford the treatment part. Let's just give them the protection. And that way, that might be the easiest way to go. Instead of like constantly doing echoes on everybody and looking for heart failure and those kinds of things, maybe the treatment part might be a better cost-effective way of doing it.
Dr. Sarah, is there any guidance on how much insulin dose we should reduce when we co-prescribe SGLT2 inhibitors?
So I'm not aware of any specific guidance, any national or international guidance, but in most of the studies, as I said, they were reducing the sulfonylurea by about 50% and reducing the dose of insulin by about 20%. Of course, that is, as Peter said, in patients with type 2 diabetes, because this isn't licensed in type 1.
And for SU people, let's move them. I always tell my patients, SU is like the old flip phone, the old flip phone that we used to have.
Worse.
So I don't want you to be on the old flip phone, where you can't hear anything. So we want to upgrade them. So the SUs, if you have patients on SUs, let's upgrade them, because I think that would give them good protection for sure.
It's been a great 2 hours and we have learned. Speaking to everyone who is logged in with us, once again, thanks for being with us. Dr. Sarah, in one word, would you like to answer this question? Did you learn anything new today?
I always learn lots when I listen to Dr. Lin.
And Dr. Lin, have you been able to decode now the nexus between the heart, the kidney, and the pancreas?
I learned so much from you, Sanjay, and to Sarah. From you, I learned all about these ethnic words that I can start thinking about as I'm seeing my patients. And Sarah, you putting together the whole milieu, this whole picture, and allowing us to say we can do something. So primary care people that are not specialists in this area can do something. I love the slides about the safety. Imagine it's very safe in heart failure patients and CKD patients. These are the patients that we're most afraid of, and they're using these things and they're having placebo-like side effects, right? So that makes me reassured that we can do this in our patients. And the good news is that we can keep them well. That's our really good goal.
On this positive note, please allow me to conclude. I'd like to thank Dr. Sarah and Dr. Peter for wonderful talks. Thank you for your expertise, your experience. We appreciate the energy, the enthusiasm that you brought into preparing these talks.
And thank you to everybody listening. We know you've had a busy day. Thank you so much for giving up your time in the name of helping patients.
And thank you, Sanjay. Your story at the beginning set the tone of everything. Thank you very much.
Thank you, everybody. Have a good day ahead, and we wish you all the best. We pray for peace and prosperity across the world. health and harmony, and health and harmony for each and every patient who comes into our contact. Thank you, everyone. Have a great day ahead.
Thanks very much. Take care, Sanjay. Bye, Sarah.
Thank you,
Okay.
Sanjay.
Bye-bye.
Bye.